And so that's a real problem related to the Medicaid cuts. It just leaves a dearth of providers in certain regions. Thanks.
Senator Hassan. Thank you. You said a couple things I want to talk about as well. Mr. Topping's response was pleasing to me. And what you talked about is the difficulty that a provider has in providing services to veterans. And it's what we lived with. I mean, choice, in my view, the VA has always been reluctant to promote choice, and in some instances has made it difficult to be utilized. And I understand that. Nobody wants to lose a patient, and veterans, the people who work at a VA hospital, care for patients, and they want to continue to do so. But the Mission Act was a replacement for choice. And the Mission Act was designed to make it more easily attainable, the providers in the community who would want to provide services to a veteran through now Mission. And it was designed to eliminate the barriers that a private provider would face in dealing with the VA. The referrals, the record keeping, the rates charged. There's just a whole list of things that we attempted to requiring the payment of Medicare rates. And we still have a long way to go. I visited every hospital in Kansas numerous times, and 50-some of them last year. And I always ask this question, and the answer is generally it's getting better, but we still have problems in getting authorizations. We need another referral for an X-ray or lab work, and I hope that in the process, not only related to these contracts, that in the process we're simplifying the opportunity for community care providers to meet the needs of veterans. That makes sense and true?
Mr. Chairman, it does, and I have yet to meet a provider who has said that they don't want to provide care to veterans. Most providers do. It's incumbent upon the VA as the contracting agency to make this program as easy to participate in and as smooth. There are ways to do that. We've addressed that during this in this program design, working on how we do the referral, how we do the eligibility, how we do the authorization, and then most importantly, how we make sure payments are made promptly, correctly, and accurately.
Senator Hassan also talked about continuation of care. It is an issue. I mean, I 2 years ago brought to the attention of the VA that a veteran in my hometown was receiving cancer treatments. He was required to receive 17 of them. After the 15th one, the VA decided that they should move the care out of the community. The first 15 treatments that he'd received in the community, the last 2 he was required by the VA to return to the hospital for those treatments. And the explanation was, you don't live 60 miles from the VA, you live 59. The drive, I said that wrong. The drive is 59 minutes, not 60. Therefore, you're ineligible to continue to have the care provided for by the doctor, the provider that you have been using for the first 17 of your treatments. I assume this is an anomaly. I assume it doesn't happen. I assume that people have common sense, and I don't know how you legislate this stuff, but this idea that Senator Hassan raised about once you start with a community care provider, and most recently I would say the time and time again, chiropractic care has been called back to the VA after a veteran has been receiving chiropractic care in the community for months or years, and the VA wants to change the provider by bringing it back in-house. I assume we will attempt to avoid those kind of circumstances, and I mostly wanted to make sure that you know that that circumstance has existed.
Chairman, I do, and I'm aware of that specific case, and I do think it was an anomaly, but an unacceptable one nonetheless. One of the things that we are doing again in NextGen is the use of utilization management in which the treatment matches the diagnosis. And so part of what we've had now is the authorization does not necessarily match. These have been separate in each other. So the idea, though, is that when we refer a veteran out for cancer treatment, that the care that is then provided to that veteran in the community would match the diagnosis. We'll be able to manage to that and manage to the quality and the cost, and particularly as we look at how we manage this program internally. Again, it's very manual now between the referral, which is a relatively well-understood clinical process. The treating physician says we're going to refer the veteran out, but then the eligibility process, the appointment-making process, the time and distance process, that's been very manual. That needs to be automated. That entire process should be relatively seamless, and it shouldn't be something that the veteran has to get involved in. It should be something that between VA as the program manager and the payer works out directly with the provider. We are working on those in this procurement. Yes, sir.
Follow up with you and further questions about it should be to make sure it will be. Senator Duckworth.